Hi, good morning. Thank you, Mr. Chairman, and thank you to the ESMO Young Oncology Board for having given me the opportunity to take this interesting session regarding different molecular subtypes of colorectal cancer and its derived implications. Okay. These are my disclosures. Okay, here is my first slide. This is a very busy slide, so let me help me to take you through. Here we see how colorectal cancer is the seventh tumor with most average of mutations, and this is very interesting because we see how it's just squeezed in the middle of a group of tumors that we clearly see that are caused by clear carcinogenic agents. However, in colorectal cancer, we don't know any carcinogenic agent that could be taking part of this tumor. If we see later in the details, we can explain this phenomenon because we see that here in colorectal cancer we have two clear kinds of tumors. We have a group of tumors, not hypermutated tumors, and a group of hypermutated tumors that maybe can push the average number of mutations in colorectal cancer and could explain this fact that colorectal cancer could be in this group of the top most mutant tumors. If we get into more into details in the group of hypermutant tumors, we can see how there are two different populations of tumors. We can see here in the green screen a group of tumors with problems repairing the mismatch errors that the DNA polymerases commit when repair the DNA. And on the other hand, we have a second group of tumors with polymerase E mutations that are even higher hypermutant. There are very interesting cases of colorectal cancer. This is very interesting because this could have different behavior in the clinical setting, and it's very important to identify these subclasses of colorectal cancer just to give to the patients appropriate treatment options. If we pay attention more specifically in the mesocyte tumors, we see that these tumors have a better prognosis when are localized, but on the other hand, and this is very interesting, has a worse prognosis when they are metastatic. They are enriched in the left column, tend to be more undifferentiated tumors, and are more prevalent in women. However, we don't have not solid data regarding different patterns of sensibility or response to classic chemotherapy agents, but on the other hand, it had demonstrated to have increased sensibility to anti-immune checkpoints agents. This data was presented in ASCO, and we see how these tumors, because they have more mutation pattern, they have more tumor antigens, and also they produce an increased immune anti-tumor response. We see here how these tumors are more infiltrated with lymphocytes, which are the red spots, in comparison to the non-hypermutant tumors. And this makes that the tumor has to create a defense that the tumor do by overexpressing PD-L1 ligand. Here we have the hypermutant tumors, and here we have the non-hypermutant tumors. And see how the hypermutant tumors express more amounts of PD-L1 just to defend against this increase in lymphocyte infiltration. And this leads you to the possibility to treat these tumors with anti-PD-L1, PD-1 axis agents and obtaining a very good response. Here we see in red the patients with deficient mismatch repair that were treated with anti-PD-L1 agent pembrolizumab, and we obtain a 60% of response rate. This is a very interesting response rate because it's in chemorefractory patients. So it's very interesting to identify these patients and expose them to anti-immune agents. Regarding the other hypermutant population, we have a very weak data regarding this particular colorectal cancer subtype. This particular subtype was firstly described in the TCGA data on 2012, and for that it's a recent discovered subtype, so we have not any solid data. But what we know for the moment is that there are not any clinical or pathological characteristics that could define this population, and that to having mutations in the exonuclease domain of polymerase E has not any prognosis of predictive implications to any treatment. But on the other hand, we know that these tumors have a higher number of mutations in comparison to those tumors with deficient mismatch repair. So it would be very, very interesting to explore the action of anti-immune agents also in this population, and this had not been already done. So it would be very interesting to identify these patients and to offer them anti-PD-1 and PD-L1 agents. On the other hand, if we pay attention, and in spite of differences in the molecular characteristics of the hypermutant tumors compared to non-hypermutant tumors, we see how the hypermutant tumors have much increased number of mutations in very different proteins, we can see how these mutations cluster in 5 different pathways that are common to non-hypermutant tumors. So in spite of having these mechanisms to have more mutations in the tumor, the mutations also cluster in these 5 pathways that are the pathways that push the tumor to acquire an aggressive phenotype. These pathways are the Wnt beta-catenin pathway that we have here in blue, the MAP kinase and PI3K axis that we have here in red and in green, the TP53 pathway we have here in violet, and here the TGF-beta that we have here in green. So these pathways constitute the nucleus of the colorectal cancer, and having drugs just to hijack these pathways and interfere them would be very interesting for our patients. Here we have a clustering and a functional analysis of these pathways, how they interact each other, just to produce that a normal cell could evolve in a stepwise model just from a normal epithelia to a given tumor. And this alteration has been well described, and it happens like this. The first alteration, what we know is the gatekeeper alteration in colorectal cancer, is the dysregulation of the Wnt pathway. When Wnt pathway is deregulated, clearly activates MEK, and MEK causes the proliferation of the basal cells in the normal intestinal epithelia, and they accumulate, causing an early adenoma. Then, immediately after, the dysregulation of the PI3K MAP kinase pathway causes an increase in accumulation of these cells, acquiring a little bit more malignant phenotype, causing what we call a medium adenoma. Following that, we lose the activity of TGF-beta. TGF-beta is an important regulator of the MEK function, particularly in the intestinal epithelia. So when we lose the function of TGF-beta, MEK gets even more activated. So we shift from a situation of a middle adenoma to a developed adenoma with high levels of dysplasia. And finally, when we lose the function of P53, which is the protein that controls the genome stability, we get the final tumor able to infiltrate and also to produce metastases. If we take a deeper look in these pathways, the Wnt pathway, which we see here, is a very interesting pathway. It's a very simplistic pathway, as you can see here in the slide, that had been very conserved during evolution of the species, and it's very simplistic with very little number of elements interacting each other, just making very difficult to interfere this pathway from a pharmacological perspective. In colorectal cancer, the vast majority of molecular alterations in this pathway have been described around this part of the pathway, which is called the destruction complex. And it's a complex responsible for degrading beta-catenin, just to preclude beta-catenin to go to the nucleus and activate the vast majority of genetic problems that this pathway causes. And by doing that, when beta-catenin goes to the nucleus, when it's produced the activation of MEK. The only drug we have currently to interfere this pathway is the Wnt-974. It's a porcupine inhibitor of Novartis. As we see here, this drug directly blocks porcupine, but we can see, given that the most molecular alterations in colorectal cancer are here, this drug clearly acts upstream, so there's no room for blocking Wnt beta-catenin pathway in colorectal cancer. But very interesting situation, recently, the group from Levi-Garraway at Boston revisited the data from TCGA, and they discovered that in fact there were a subset of colorectal cancers that had a parallel molecular alterations responsible for activation of the pathway, and these molecular alterations could confer sensitivity to colorectal cancers to this pathway. So at least this population that accounts for around 20% of colorectal cancer could be treated with this drug. And for the very first time, we have a possibility to block the Wnt beta-catenin pathway in colorectal cancer. And this is very interesting because, as you know, this is the gatekeeper molecular alteration. And if we pay attention to the subclone evolution of tumors, if this is the gatekeeper molecular alteration, it will be presented in the vast majority of tumor clones, and by blocking these in the sensible tumors, we theorize that we could get a very good responses. Going further, the second important pathway is the PI3K MAP kinase nexus. When this pathway is activated, we move from a situation of an early adenoma to a middle adenoma. As you can see here in the slide, MAP kinase pathway and PI3K pathway, they are very interconnected pathways that work together, causing very high amount of difficulties in blocking the pathway, because when we block one of the pathway, the other immediately gets overactivated, causing resistance to treatment. The most frequent dysregulations in these pathways, you can see it in the slide. This pathway could be overactivated at high amount of levels in colorectal cancer, 60% of RAS mutations, 5 to 10% of BRAF mutations, 1% of MEK mutations. PI3K are mutant, tumors are mutant in PI3K around 20% of cases, and also we can also have mutations on PTN and IKT. Regarding the subgroup of RAS mutant tumors in colorectal cancer, we know that RAS proteins could be mutated in around 60% of colorectal cancer, and this confers a clearly pattern of resistance to anti-EGFR monoclonal antibodies. And also, it has been also theorized that different mutations in different exons of RAS proteins could confer different prognosis implications in the metastatic disease. We know that thus far, RAS has been out of therapeutic reach. We cannot directly block RAS. What we have done in early clinical setting is trying to design combinational strategies trying to block the main RAS effectors. And thus far, it has been tested, both strategies trying to blocking RAS signaling. The first one is what we call the parallel strategies, trying to block both pathways at the same time, trying to block MEK, which is one of the main effectors of KRAS, and also trying to block at the same time PI3K. Just trying to block the signal from KRAS. The other strategy that has been tested is the sequential strategy, which consists in blocking MEK, the main effector of KRAS, and also blocking at the same time the membrane receptors responsible for activation of the signaling in the pathway, because we know that when we block the pathway, there are several numbers of activating feedbacks that could reactivate the transduction of signals through the pathway by overexpressing the membrane receptors. Both strategies have been tested in early clinical setting, but have not provided interesting results thus far. Regarding BRAF mutant tumors, we know that in colorectal cancer, there have been described that the tumors could be mutated from 5 to 10% of cases. BRAF mutations are mutually exclusive with RAS mutations, and when we have a BRAF mutation in a tumor, we know that this is a driver mutation that confers a very bad prognosis. Tumors with BRAF mutation tend to live almost the half of normal tumors that don't harbor BRAF mutation. That BRAF mutations confer different pattern of sensibility to chemotherapy drugs, and that these patients can really benefit from exploring BRAF inhibition in combination with other drugs, as it will be presented tomorrow in this Congress. Regarding the PI3K mutations, the role of PI3K mutations had not been elucidated yet in colorectal cancer. We know that PI3K could be mutated in around 20% of colorectal tumors. The vast majority of mutations in PI3K are found in the exon 9 and exon 20. The most frequent is the exon 9, but we don't know any prognostic or predictive role of these mutations in colorectal cancer. On the other hand, the mutations in exon 20 are less frequent, had no prognostic implication, but it had been theorized that they could somehow confer a certain pattern of resistance to anti-EGFR agents. However, this has not been demonstrated in the big analysis of the big trials exploring this agent. What we really know is that the PI3K mutations acquisition is a late event in the evolution of colorectal cancer, and perhaps could be a role in the acquisition of chemotherapy resistances, that as these mutations I acquire after chemotherapy treatment in colorectal cancer. And finally, the rest of two pathways involved in colorectal cancer, the loss of TGF-beta signaling and the loss of P53 functions, are tumor suppressor pathway, thus they have been not therapeutically explored in colorectal cancer for the moment. This is a nice overview slide. We know that in colorectal cancer there is a core of molecular alterations that is responsible for pool of the disease. The tumors have to be a MEK overactivation, P53 loose, and overactivation in MAP kinase PI3K signaling. This is because we have several different alterations in different pathways that are responsible for activate this core and maintain this core during evolution of the tumor. And for the moment, we are only able to interfere this core in a very, very minor populations of colorectal cancer. We are able to block a minor of patients with Wnt activation. We are able to block that patients with have AGFR ligand overexpression, that patients that have BRAF mutations are probably the patients that have PI3K mutations. But the vast majority of patients with colorectal cancer are, for the moment, out of therapeutic reach. And maybe perhaps this is explanation why the current results with drug development in colorectal cancer are so poor. Trying to shed some light over the situation, the Colorectal Cancer Subtyping Consortium try to organize and to try to look for different classifications. Here we have been talking about different colorectal cancer subgroups at the DNA level, but as we know, the cancer battlefield happens around the proteinic level, where definitely the cells function, and is where definitely are the alterations that lead cells to become malignant cells. So what the Cancer Subtyping Consortium did is trying to look at the RNA level, which is closer to proteomics. We are not yet to arrive to a proteomic level. It's so complex, we are not ready, but at least we can look at RNA level, trying to give a different perspective of the problem to give better results in the treatment of these tumors. What they did is they took the data from all the gene subtyping signatures that were published thus far. We know that there were 7 different gene signatures that they were able to classify colorectal cancer disease in different subtypes, but on the other hand, there was not a solid consensus among all of these. The data was highly different. What they did is to revisit the data produced by all these gene signatures, trying to elaborate a consensus subgroups more solid than the prior one that we could use on the clinical setting just to offer to the patients different treatment options. And what they obtained is they were able to classify the colorectal cancer in 4 different subtypes that they call like consensus molecular subtypes from 1 to the 4. They found that the consensus molecular subtype number 1 was present in around 14% of patients, and that were tumors characterized by an increase of the average of mutations. They were hypermutant tumors, and these hypermutant tumors were more related, more prone to have BRAF mutations, and were more prone to have immune infiltrations in the tumors, and also they had a worse survival after relapse in the metastatic setting. On the other hand, they found a second molecular consensus subgroup, the CMS2, that were called the canonical subgroup because they were pushed by the acquisition of Wnt dysregulations and MEK activations. These patients had a better survival after relapse in the metastatic setting. Even more, they found a third molecular subtype that called the metabolic subgroup that was caused by the acquisition of metabolic dysregulations. One of the most frequent alterations were the acquisition of KRAS mutations, and they were all defined by the metabolic dysregulations. And finally, they found a fourth molecular subgroup accounting for 23% of the population that were defined by increase on the expression of TGF-beta controlled genes, and they were tumors characterized by a proliferation of the stromal tumor. So they called the mesenchymal subtype. Using the data produced by this consortium, there's currently taking place a European collaborative consortium that has tried to use this information to give to patients 2 different treatment options according to the classification of the transcriptomic subtypes in colorectal cancer. This initiative has been supported by the obtention of a Horizon 2020 grant, and it's a clinical trial trying to be set up, a collaborative clinical trial among different European institutions trying to be setting up to start early. And what they are trying to do is to pair these different molecular subtypes to different treatment options according to the transcriptomic profile. So we know that the more hypermutant tumors had better outcomes when they are treated with immunotherapy. So they are trying to allocate the patients having an immune transcriptomic phenotype to receive immune checkpoints. And on the other hand, those patients with a more mesenchymal transcriptomic signatures that had an increase on traduction of TGF-beta related genes would be treated with TGF-beta inhibitors in combination with other agents, maybe chemotherapy. And finally, these other subgroups with a not so clear treatment pair would be treated according different drugs using different subclassifications between these two subgroups. And finally, my conclusions is that we know that the molecular basis of the disease are clearly established. However, the different and the most frequent drivers of the disease are currently out of reach from a therapeutic perspective. To improve the current panorama of colorectal cancer in our patients, we need to expand our therapeutic armamentarium, achieving new drugs, being able to drug the drivers of the disease. And we need, for sure, new experimental models, more capable to make us the understanding of what happened when we start at a molecular treatment and we don't get responses and we achieve resistances. And thank you so much.